Okay, great, good. So I was very explicit in my instructions that I hope you got, that this is not going to be a lecture. You've already had your peripheral arterial disease lectures over the years. So this is a question and answer session. This is an opportunity for you to ask me what you need to regarding anything vascular disease related. All right. So the ball is really in your court and I will take questions. All right. So you just have to raise your hand and I'll acknowledge you. I hope you got the message, but I see no benefit in giving a lecture at this juncture. Okay, I see Matthew White's hand went up. Go ahead, Matthew. Good morning. Okay, thank you for your question, Matthew. All right, first of all, I do not think it is reasonable to ask a med student anything about whether it is surgery. Are you going to do surgery? Are you going to do angioplasty? What technical aspects of the surgery? I don't think it's reason to ask any question like that. So you may have been asked. I think if I were asking questions about the technical aspects related to surgery, it would be in the context of having a patient on the operating room table and expecting that the med student has read about the case, because you're supposed to prepare for your cases before you come to the operating room. So you should have an idea of what we're going to be doing. You shouldn't be just out there in left field. But in terms of asking a med student about technical aspect, when do you do balloon angioplasty versus a bypass? That is way beyond the scope of a medical student. I have never seen such questions come in your MBBS multiple choice question regarding technical aspects. And I don't think it's a good use of your time to spend doing that. I have, even in your OSCE, again, you know, while you should understand the principles, and I'm going to talk to you in a second about some of those principles, while you should understand the principles of bypass surgery, you should not be expected to go into any more detail than that. Okay, so let me just go over some of those principles. So the first, what you do need to understand is, because many of you are going to be those doctors in primary care a few years from now, for those of you who don't specialize, or even if you become an internal medicine doctor or an emergency room doctor, what you do need to realize is that you cannot just keep dressing an ischemic foot. You cannot keep dressing a gangrenous toe and expect that the patient is going to heal. It does not matter what you put on that foot or what you put on that toe. You cannot just think that you're going to put a patient on Trental who has rest pain and that the problem is going to go away. All right. And I see far too many doctors in the periphery or primary care doctors who will keep a patient in their office for 6 months just dressing a wound. And that is really unacceptable. So if it's one thing you remember from this morning, it is, if you have a non-healing wound, there usually is a reason why, okay? And so your job in understanding peripheral arterial disease and peripheral venous disease for that matter is the why, all right? And that the patient needs to be further evaluated. So when you get an angiogram, and that could be any kind of angiogram, that could be a CT angiogram, could be a MR angiogram, could be a conventional angiogram, but when you do any kind of angiography, you are looking to see, you're saying, okay, I have a non-healing wound. One moment, please. Let me look. So when you have a non-healing wound, your job is then to say, this looks like an arterial wound, all right? And please remember, it's not you need to know the difference between arterial and venous wound. That is where you should expend your time, because in your clinicals, you may be given a patient who has a foot wound or a leg wound, and you will have to know if it is arterial or venous, all right? So that is where you should expend your time, not on the technical aspects of surgery or procedures, but on being able to have a convincing discussion as to why this is an arterial wound or why this is a venous wound, and how you're going to work it up and how you're going to treat it. So let's go back to arterial wounds. So if you have an arterial wound, and you, can I revascularize? Because drilling alone is not going to help that. The blood flow, and in improving the blood flow, pain. So that's where your angiogram comes in. And when you get your angiogram, are you hearing me?
You're breaking up a little. I'm not sure if it was just for me.
Okay, all right. Are you hearing me now? Okay, all right, good. So when you now get your angiogram, you are looking at the inflow, or as you said, Matthew, we don't really call it running, but I guess you can call it that. But usually the term we use is inflow. So we're looking at the inflow. Where can we get the blood from? Okay, so in many cases, the common femoral artery, all right, you're hoping that the system is at least patent up to that level. And then you may have an occlusion, say, for example, of your superficial femoral artery, and then you are looking for outflow, all right, which we do call runoff. Well, the runoff is usually into the tibial vessels. So you're looking to see, where do I get blood from to effect this bypass? Where do I take blood to, all right? And what material am I going to use? That we call material is usually a conduit. What material am I going to use? So, or am I going to utilize conduit? Some kind of conduit like PTFE would be the most common. Okay. We are also looking, and bypass as a general principle, not all the time and not for every patient, because you have to take patient video into consideration. Is it an old patient? Is it a debilitated patient? Is it an ambulatory patient who walks, who doesn't walk? All of these things have to be taken into consideration in planning your approach. But one of the things you're also looking at on the angiogram is this a candidate for angioplasty? And you wouldn't to describe, you should be able to describe the findings of an angiogram, right? Because you should know the vascular anatomy. You should know that the comma comes the external iliac, branches then to external and internal iliac. Iliac will go under the bifurcation femoral artery, which will become the popliteal at the adductor hiatus. Your beyond that, you will transition to the below knee popliteal and to the tibioperoneal trunk. The first takeoff from the tibioperoneal trunk is the posterior tibial, and then your posterior tibial and your peroneal will basically, there's another bifurcation, right? So that you should understand. And if it puts an angiogram in front of you, you should be able to say, this is a blocked superficial femoral artery, okay? And that the patient would need revascularization via bypass angioplasty or angioplasty, or in some cases, a combination of the two procedures, which we call a hybrid procedure. All right, so that is what you need to understand. You need to understand the principle much more so than the technical aspects. However, I continue to say that if you're going to be involved in a surgery and it's your patient, you can't walk into the operating room not knowing anything about the surgery. You have to at least have an idea that an incision in the groin, they're going to make an incision below the knee, and they're going to harvest vein, right? It would be reasonable to expect you to know that, but nobody's going to ask you about super technical aspects in your exam. I hope I've answered your question, Mr. White. Okay. All right. Questions?
Yes, doc. Say that we're shown, sorry, good morning, Dr. Brown. If we're shown an image and it's like showing gangrene, right? I just want to know, how do we know to direct the conversation PAD versus diabetic foot? Because diabetes can be a cause of PAD and there can be some overlap. So how do we know when to direct the conversation in one area versus the other?
Okay, that's actually a very good question. Good morning.
Doc, you're still breaking out.
Okay, I'm asking, is it Chelsea? Oh, hold on. Is it Chelsea who asked the question?
Yes, Dr. Brown.
Okay, all right. All right, so that is a very good question. All right, so for the most part, diabetes, a diabetic foot, for example, is not going to present as gangrene, right? An ischemic foot would present as gangrene, all right? So the patient with an ischemic foot may have diabetes for sure, right? Because that's one of the risk factors. But if you have toe gangrene, for example, and hyperpigmentation, you should be directing the conversation to peripheral arterial disease, and it's more specific to critical ischemia, okay? Remember, a diabetic foot is going to look a bit different. A diabetic is going to have a diabetic foot is going to have ulceration that is over the pressure points. So at the metatarsal heads. Now, the wound may look a little bit necrotic, but it's going to have a more characteristic location. In fact, a diabetic foot patient may actually have palpable pulses while having a neuropathic ulcer over the metatarsal head. So if it's frank gangrene on the toes, frank hyperpigmentation, it's more likely that the primary issue is that the patient needs revascularization as opposed to the location over the metatarsal heads. And sometimes it's not 100% clear cut like that, but I think for the purposes of your exam, that the patients who are selected will be pretty clear cut. It doesn't make sense to bring you a patient who, where there's a question of whether it's an arterial wound, a venous wound, or a diabetic foot ulcer, right? It really wouldn't make sense, would not be fair to do that. So your venous ulcers, on the other hand, are going to be in a totally different location, right? They're going to be around the malleoli. So that's my answer to your question.
Okay, thank you.
You're welcome. Further questions? Okay, Matthew, is your hand up again? You have another question? Sure, go ahead. What you mean? You mean the most common surgical complication? Oh, all right. Okay. So I see 64 of you here and the questions are not coming in. So I suspect some of you came here expecting a lecture this morning. So I'm going to just call on somebody and I'm going to ask you what are your general complications of you expect. Adeniki Gordon. What are general complications that you can expect in a post-surgical patient? For example, who has had a lower extremity bypass. Ms. Gordon, are you there? All right, let's move down. Sashana Carr, what are general complications that you would expect in a post-surgical patient?
Okay. So complications can either be early or late. So early complications that the patient could have would be the patient could get a hemorrhage, for example, or the patient could get complications to anesthesia. In terms of late, specifically to graft repair, the patient could get...
No, we're not going to graft repair yet, just general.
Oh.
What other general complications can a patient have in the post-op?
So late, the patient could get, well, this is early. So the patient could get complications like atelectasis, or the patient could get deep vein thrombosis. They could get infections, either surgical wound infections. Yeah.
Okay.
Yes.
All right. So that is a start. Post-operative pneumonias. I think you left that part out. You did say atelectasis.
Yes, doc.
Okay. All right. Thank you, Ms. Carr. So those are some general complications which you would need to express for any patient, right? If you're talking about post-op complications. Specific to bypass grafting, our most feared complication is thrombosis of the graft. So, and you can get thrombosis of the graft at any point, really. You can get it early, which is usually we within the first 30 days. has to do with usually something technical, some technical aspect related to your surgery. So it could be how you stitch your anastomosis, it could be the graft under tension, it could be infection. All right. So there are many things. 30-day period, it's usually something technical related in the month. Which is basically, as it the intima begins to overgrow, it's usually somewhat reactive to the fact that you stitch the blood vessel. Occlusion. The last thing can happen after, and that is usually due to recurrence of the
Sorry, Dr. Brown, are you able to repeat what you said? You were breaking out.
All right. So let me see if I can change my location. Hold on. Yeah, so did you hear what I said about early graft occlusions?
I didn't hear you. I only heard as far as thrombosis of the I think graft.
All right, so I said within the first 30 days, graft occlusion is usually due to something technical. All right, something related to how you stitched or made your anastomosis, something related to the length of the graft, etc. Within the first 3 months is usually intimal hyperplasia. Is everybody having a problem hearing me?
Yes, doc.
Generally, yes, doc.
I can hear you clear now, Dr. Brown.
All right, well, it seems like some people are hearing and some are not hearing. So we will just have to proceed. I hope it will get better. All right, so at 3 months, it's usually intimal hyperplasia, which is, as it speaks for itself, right? Why patients would get a graft occlusion. And after a year, it's normally recurrent atherosclerotic disease. Okay, so patients get arterial disease, peripheral arterial disease, which affects the graft itself, and that can lead to graft occlusion. So those are the specific complications related to graft occlusion and why they would occur, right? Graft occlusion and why it would occur, which obviously is a possible complication of procedure. Okay. Mr. White, did I answer your question or you would like more detail? Okay. Any more questions?
Good morning, Doc. I have a question.
Yes, go ahead.
As it relates to abdominal aortic aneurysms, I just wanted to clarify, is atherosclerosis like a direct risk factor?
That's a good question. I don't really know how to answer that question, you know. I would say I would say probably no. But because atherosclerosis, I would say no. But because atherosclerosis is related, because a lot of the factors are common, right? Older males with hypertension, then you will frequently see that patients will present with an aneurysm and atherosclerotic disease. But in terms of atherosclerotic disease causing an aneurysm, I'm not sure that you can 100% say that. So I think if you are, I don't think you will be given a multiple choice question that where it is, where that is, where you're exclusively asked to comment, I don't think the answers will be so close together. That is what I'm saying. If you're doing an MCQ, we are very active about making sure that we don't have questions where the answers are so close together. I think the answer will be obvious, and you won't have to be trying to nitpick as to whether atherosclerosis is or isn't. So because it's a little bit ambiguous, because so many of the risk factors for PAD and the patient demographics will overlap with aortic disease. But it's very common. And the reason I answer no is because in a majority of my aneurysm patients, they have no symptomatic PAD. I mean, literally, they have palpable pulses in the feet. And that has been my experience over several years, right? I expect them, when I examine them, I expect them to have palpable pulses in their feet, and they usually are not complaining of any symptoms related to PAD. All right, so I don't think it's a clear risk factor.
Thank you, Doc.
Okay, you're welcome.
Excuse me, Doc. I think I got a little lost as to what exactly you were talking about. It's not the diabetic foot you were talking about a while ago?
No, not at all. I just want to know if it's an issue unique to you, or if maybe your internet tripped out. Did everybody else just indicate in the chat if it was clear what I was talking about, because it was nothing related to the diabetic foot. So Shana, it was clear. Anybody else? Was it clear what I was speaking about? Because maybe Kimberly was not hearing.
Doc, initially, I didn't hear the question, even though you were clear.
Okay, all right. The question, all right, I see what you're saying. All right, the question he asked about is if atherosclerosis is a risk factor, a direct risk factor for the development of an abdominal aortic aneurysm. That was a question. All right. So and basically I said I think of them as two distinct entities, but with overlapping patient populations. That was my answer. I hope I've clarified. Ms. Woolery, do you have a question about the diabetic foot?
Not at all, Doc. Thank you so very much.
Okay, sure. All right, nobody seems to have any further questions. So let me ask you a question. Let's see, who can I ask? Melissa Samuel, where do wounds occur that are related to chronic venous insufficiency? Where would you find those wounds? We talked about the diabetic foot wound being on the metatarsal surfaces. We talked about the PAD wound being usually the digits, specifically gangrene of the digits in many cases. Where are venous wounds located? All right, Melissa, not Sina, and Melissa saying anything. Chanel, Zamor. Oh, I see Pierre Charles. Is it Pierre you answered? You raise your hand. Is it because you want to answer the question?
Yeah, I could try. Is it that
Sure.
they typically
Go ahead.
present the medial aspect of like the medial distal aspect of the legs are above like the medial malleolus? That would be along the length of the long saphenous, and then it could also be the short saphenous on the lateral side as well in some cases.
Okay, all right, good. So the venous wounds are usually either medial or lateral malleolus. And as Pierre Charles says, so you're not going, I don't think you're going to see long saphenous in your multiple choice answers. I think you're more likely to see great saphenous. I mean, I haven't seen the paper, but I just know that that is not the, I can't promise you, but what I do know is that long saphenous is not the modern terminology for the vein. The name of the vein is the great saphenous vein, but we are referring to the same vein. All right. And then the name of the short saphenous is the small saphenous vein, and also is related to venous incompetence. In the small saphenous vein, usually present themselves at the lateral malleolus. So if you see a malleolar also, please do not come in the exam and tell us that it is an arterial wound. It's normally going to be around the malleolus. It is normally going to be pink and well vascularized. So please be able to make the distinction between an ulcer that is at the ankle, is pink, and also that is on the toe and looks ischemic, right? Two different etiologies. And for some reasons, students are often confused. And if you can't make the distinction, you are going to fail that clinical station, okay? And as night follows day, certain things are common. So you should, really expect that because venous disease and arterial disease are common, that will be part of what you'll be examined on. So you have to be able to make the distinction. All right. And that's why I just asked the question.
Doc.
Yes, Mr. Harris.
As it relates to the location of venous ulcers, patients with sickle cell disease usually have ulcers in those regions. So how do you differentiate between the two?
Well, that's a good question. You look at other stigmata, which would usually your sickle cell patients, you are absolutely correct. It could be, and that should be part of your differential that you're discussing with an oral examiner, right? That may be in your differential, but that's usually something that is obvious on other aspects of your physical exam in terms of the overall appearance of the patient, maybe jaundice, maybe not. And you may just say to your examiner, my differential diagnosis is that this could be a sickle cell also, but I would need to get more information from the patient. So I think it's usually pretty obvious upon inspection or early discussion with the patient if that's the road you should be going down. But you can certainly include that in your differential. Okay?
Thank you, Doc.
Okay. All right. But if you see a pink, well-vascularized wound, including at the lateral malleolus, because I know the reason I say it is because I've heard students over the years come to exam with this ulcers at the lateral malleolus are arterial. All right. So including a nice well-vascularized wound that is pink at the lateral malleolus, all right? That is a venous also, due to incompetence in the small saphenous vein. Okay, any further questions?
So that just confirming, I know you said it earlier. So if it is that the ulcer is on the medial malleolus, it's the great saphenous vein, right?
Yes, that is correct.
Okay, thank you.
I think many of you are referring to it as the long saphenous vein, all right? But it's actually called the great saphenous vein. And if you have a multiple choice question, it's probably going to be called the great saphenous vein. So don't get confused. I'm surprised they still print books with the name of the long saphenous. Maybe it's an old edition, because it hasn't been called that for probably 20 years when you guys were born. All right.
Dr. Brown,
Yes, Larry.
just to confirm, it is due to incompetence of these two veins in that area why the patients are prone to develop ulcers there.
Yes, that is correct. So usually what is happening is that when we say incompetence, what is normally happening is that the vein is supposed to be taking the blood from the legs back, from the feet, sorry, back up the leg to merge with the deep system, and then to return blood via the iliac vessels to the inferior vena cava to the heart. Okay. When you have venous incompetence, whether it be in the deep veins, the surface veins, or both, that action is not occurring in a, what shall I say, in a very efficient, coordinated manner. And as a result of that, the blood is actually backflowing, and as with the blood backflowing, you have a high pressure which occurs at the ankle, making it susceptible to all the forces that come with venous hypertension, and therefore susceptible to ulceration. Okay.
Thank you, Doc.
You're welcome. All right.
Dr. Brown?
Yes, Mr. Samuels.
Yes, I have another question. This one regarding diabetic foot ulcers. I know that in one of the tenets of management is like systemic control of infection via antibiotics. From what I've seen throughout lectures, they expect us to say what the coverage is in terms of not necessarily to just list antibiotics like that, but to say what you intend to cover for. What generally should we cover for on our diabetic foot?
Okay, so kind of bugs that would cover for, you need something broad spectrum, okay, but more specifically, you need to make sure you have anaerobic coverage, which would be your metronidazole, and you need to make sure you have gram-positive coverage, all right, which is things, usually any of the cephalosporins, augmenting type of thing. So we have both gram-positive coverage. So these can be colonized by multiple bugs, but the most common would be gram-positives and anaerobes in your diabetics. All right. So you have your gram-positive coverage and your in the form of some kind of cephalosporin or penicillin derivative, and you have your anaerobic coverage in the form of metronidazole. Usually for your diabetic foot ulcers, unless it is kind of, and I'll talk about that in 1 second, unless you have selected for bugs that that are resistant, you will normally be fine treating them with gram-positive and anaerobic coverage. Now, one of the things as go out into practicing is that you do not want to be putting all kind of antibiotic ointments on these wounds, all right? The Bactrobans and the triple antibiotic medications and all of those are really not going to help in these diabetic foot wounds. And what you are going to do is then select out the superbugs. So you're going to change what could be a simple gram-positive infection into something where you now are talking about gram-negatives and a worsening infection. All right. So because the topical antibiotic therapy may have managed some of the easy bugs to deal with, and you select out the bad bugs, and then when they come in with a foot infection, you're now talking about, you know, worse gram-positives or gram-negatives in the wound. All right. So these topical antibiotic therapies are, for prolonged use, are generally not a good idea. All right, the problem in a diabetic foot, as I've said already in this discussion, is usually local ischemia at the pressure points, one of those pressure points, for example, being over the metatarsal heads, and therefore you're going to get much more mileage by offloading the foot and getting rid of those pressure points when they walk. All right, so with special footwear, that's going to allow them to walk in such a way that they're not continually putting pressure on the foot. All right. Yes, if there's an acute infection, you need antibiotics, but and intravenous antibiotics or even oral antibiotics if the infection is not too bad. But your wound care and your foot care is probably even more important.
Thank you, Doc.
Okay, you're welcome. All right, so Shauna, you raised your hand. Go ahead, please.
Hi, Doc. So I just want to confirm that for the ankle brachial index, right? It's the affected leg and the upper limb that is on the side of the affected leg that you measure the pressures for to get the ankle brachial index.
No, that's not correct.
Okay.
All right. So I'm glad you asked because we need to clear that up. So who wants to say how the ankle brachial index is measured?
I can make an attempt.
Go ahead.
So so you do a blood pressure reading in both arms and both legs, and you choose the highest arm blood pressure reading divided by the
all right, you're doing
lower
good
limb
so
blood
far.
pressure reading.
You're good, you're doing good so far. All right, so you do the blood pressure on both arms and you use the higher arm pressure. Is that your numerator or your denominator?
The arms would be a
The
numerator.
No.
The denominator, Doc.
The denominator. All right, listen, you guys are just a couple weeks away from exams. You need to know this, so I'm glad you asked. All right, so the denominator, it's the ankle brachial index, right? Ankle is the numerator, brachial is the denominator. Ankle over brachial. All right? So, all right, because Miss Harvey, and that would only make sense, right? Because your ankle brachial index is usually 1 in a normal patient, maybe a little bit over 1. All right. If you were putting the numerator as the brachial and you had a low leg pressure, you would always get a really high number, right? So it must be the other way around. Just think of it, ankle to brachial index. So the brachial is your denominator. All right, Ms. Harvey, continue now. What pressure are you using in the legs?
I can't remember really.
All right. Okay, who wants to assist?
Posterior tibial or the pedis, dorsalis, the higher one.
Yes. So good. So you measure the pressure at the dorsalis pedis and the posterior tibial on each leg. All right. You have an ankle brachial index, don't really have anything to do with the affected side. Ankle brachial index is for each leg. So you measure the dorsalis pedis and the posterior tibial on each leg. And not sure who just said it, but as he said, you use the higher pressure. So if you're on the right leg and your dorsalis pedis is higher than your posterior tibial, that is your numerator. All right. If you're on the right leg and the posterior tibial is higher than the dorsalis pedis, that is your numerator. So it's the ankle pressure divided by the brachial pressure, and you will have a number for each leg. And it is important that you measure both sides. All right.
I have a question. So why would we use the higher pressure?
Why?
Yeah, if it is that, for example, the right leg was good, the left leg there was an occlusion, so it was. Why would we use the higher?
All right. First of all, question. 1 second. So I want to make sure that the basis of your question, that you're asking a question based on an understanding of the ankle brachial index. So I'm going to put it back in your court before I answer the question, because the way you phrase it make me a little bit unsure that you understand how to measure it. So Pierre Charles, tell me, you have a patient in front of you. How are you going to measure the ankle brachial index?
Okay, doc. So you said that you'd measure the brachial pressure of the two upper limbs. So I would do the left and the right upper limb. And I'd also measure both the posterior tibial and the dorsalis pedis of both lower limbs, and then place the highest pressure from the lower limb over the highest pressure of the lower limb. Dependent on the value, then that would basically tell us the severity of the occlusion or the ischemia in limb.
All right. So I'm glad I asked you to repeat it, because based on your answer, I don't think you get it.
Okay.
Each leg has an ankle brachial index. It's not one ankle brachial index. Is that clear to you, Pierre Charles?
Okay, yeah.
Is it clear? Is that your understanding? Each
No, it was one, so.
right. That's why that you never. All right. So make us go back over it again. It's not one ankle brachial index. You have an ankle brachial index for the right leg, and you have an ankle brachial index for the left leg. Okay. So you measure the pressure in both arms. You have one pressure you're using from the arm, which is the higher pressure. But each leg has an ankle brachial index. So then you go to the right leg and you measure the pressure at the tibialis posterior and the dorsalis pedis. And you get a number for the right leg using the higher number. And then you divide that by the higher arm pressure. And now you have your ankle brachial index on the right. Then you go and you measure the dorsalis pedis and the posterior tibial on the left leg. And you take the higher one of them and you divide it by the higher arm pressure. So you have a high ankle brachial index for the right leg and an ankle brachial index for the left leg. Is that clear?
Yeah, that's clear. Thank you.
All right. So you're looking at each individually. So now that you understand that, I'm not sure that you need to ask the first question that you asked. Do you? You still need to ask a question?
No, I understand that, Kristen.
Okay, good. All right.
So,
Go ahead.
excuse me, Dr. Brown.
Yeah.
So if I was asked to do the ankle brachial index for a patient, I would come with two readings then, one for the left leg and one for the right leg.
Yes, that is correct.
Okay.
Correct. Exactly. Now, sometimes when we're on ward rounds, we might, the terminology might be loose. I come on the ward round and I said to the patient, I said to the resident, so what's the ankle brachial index? And they tell me 0.5. All right. But I'm asking about what is it on the affected side, because I'm trying to make a clinical decision about the affected side. But that don't mean that is just one ankle brachial index, because the ankle brachial index on the right could have been 1. You understand? So I think that that is what is the source of confusion, because on ward rounds, you will hear, oh, the ankle brachial index is 0.5. So you might think that that is what it is. But that is we are interested in the affected leg. If the right leg is fine, right? Then we're not really discussing the right leg. So when I say what's the ABI to the residents, they're telling me what is the ankle brachial index on the affected side. All right. So maybe that is the source of confusion, but there would have been an ankle brachial index on the right side as well. Okay. It's just that it's not really relevant to the discussion which we're having right now. All right. Or sometimes if you're listening clearly, what I would say is, what's the ankle brachial index? They tell me 0.5. And then I want to have some perspective in my mind. So I'll say, oh, so what is it on the other side? And they tell me 1. And then I know that it's really significantly depressed and both sides are unequal. All right. So that may be the source of confusion, but each leg has an ankle brachial index. But normally we're having a discussion about one leg. And that's why you may have thought that is just one number, but it's actually 2 numbers. All right. Okay, so I hope I cleared that up. Are there any more questions?
Sorry, Dr. Brown. Okay, I think this is the same question we had asked. I think that's here. Okay, I know we used the highest, at least I was aware of us using the highest systolic pressure of the arm. But I wasn't aware that we used I know it's 2. You measure both actually measure all the limbs, or 4 the limbs. I don't know, you use the highest for the arms, but I wasn't aware that we used the highest for let's say for the left limb. I wasn't aware that we used the highest. So it makes a difference if we use the highest or the lower value.
Yes. Hold on, let me just make sure. Yes, you have to use the higher value, because that is the reason you use the higher value on the affected, on each side, is because that is a measure of how much blood flow is going to the foot, right? You could have an occluded dorsalis pedis artery where you're getting an ankle brachial index of 0, frankly. 0 over anything is 0. right? So, but you could have a posterior tibial artery where you're getting a pressure of 100, right? So if you use the 0, then it would look as if there's no blood going to the foot. So you'll use the higher one because that is a measure of how much blood is going to the foot.
Thank you. That's the thank you.
You got it?
Yes, ma'am.
Yeah, good. All right, because if you have 0 at, for example, the dorsalis pedis, let's say the numerator is 150 for argument's sake, and you have 0 at the dorsalis pedis because the anterior tibial and dorsalis pedis are occluded, and you have 100 at the posterior tibial, because then basically the amount of blood flow that the patient is getting, 100 divided by 150, is basically almost 0.7, right? So they have an ABI of 0.7, all right? And that's how much blood the foot is getting, even though the dorsalis pedis is occluded. So that's why they use that number. All right, Selena. Oh,
Sorry,
Doc. All right, so here's what we do. Carla, you look like you have a point of order, so go first, please.
All right, I have a very basic question, so forgive me. My question is, when we're measuring the anchor-brachial index, we use the Doppler, right?
Yes, that's right.
Okay, because that's what I've
Yes,
seen done.
yes,
All right,
you're supposed to do it properly. You should have a handheld Doppler. Yes, correct. All right, so I think it's Selena who had her hand up. Go ahead, Selena.
Yes. Good morning, Doc. I was just going to ask if you're gonna run through the formats when examining a foot.
No,
Later.
I'm not going to run through the format, but how about you do it?
Okay, so from what I know, it would be inspection, general inspection, and then inspection of the wound itself. So you describe the characteristics, and then you check for the pulses, and maybe say you'd want to do a ankle brachial index.
So tell me how and where you check for the pulses.
Okay.
You're correct so far, but you have to be more detailed on checking for the pulses. How are you going to do that?
Okay, so it'll be proximal to distal.
Right, that's correct.
Yes, starting with the femoral and then the pubic.
Yeah, where you find the femoral pulse?
So that's between the ASIS and the pubic symphysis, halfway, and
Okay.
one.
And what?
No, 1 centimeter below that halfway mark.
Just about. All right, where you find the popliteal?
Popliteal is behind the knee.
Yeah, where behind the knee?
Like in the midline.
Yeah, a little bit more medial. All right. Okay, so it's a little medial to the midline. And in what position do you hold the leg in order to feel the popliteal pulse?
The knee, it should be flexed at the knee.
Yes, and it's passive flexion, right? You are flexing the knee for the patient. It's not active flexion. If you tell them to bend the knee, you're not going to feel it. Good. And then where you feel for the dorsalis pedis and the posterior tibial?
Okay, so the dorsalis pedis, it's okay. So extrapolate up from the second web space, in the midfoot area.
All right. I think to be more specific, you're looking for that tendon that goes to the first digit. And in the midfoot, just medial to that, that's where you feel a dorsalis pedis. And where do you feel your posterior tibial? Selena, I noticed you put.
Oh, sorry.
Yeah, where do you feel the posterior tibial?
Yes, it's usually between like the flexor digitorum longus and the flexor hallucis longus.
The posterior tibial?
Oh, okay. It's where the medial malleolus, like behind the medial
Yeah,
malleolus.
behind the medial malleolus. Okay, so yeah, that's how you do the exam. All right, so you inspect, you say what the ulcer looks like, describe the characteristics of it, describe the location, be as graphic as possible. Remember, I always tell the students, you're trying to paint a picture for somebody. A lot of times when you're talking next year, when you're talking to the residents, you will be on the phone. So you literally have to paint a picture for them of what the wound looks like. Where is it? Is it pink? Is it necrotic? What is the size? All right, does it have any surrounding features, etc., etc.? All right, I'm going to take the last question now from Chanel.
No,
Wait, hold on, I heard a protest.
yes, doc. I just wanted to confirm exam style, right? On palpating the pulses, if we feel the most distal pulse, we don't have to palpate the other pulses?
No, you need to palpate all of them, and you need to start at the femoral and work your way down, like we just spoke about.
Okay, all right.
Generally speaking, if you have pedal pulses, you will feel everything proximal, but it's not okay to skip examining them because there is the occasional patient with syndromes that we don't need to get into right now, who will have palpable distal pulses, but not femoral. But that is highly unusual, but especially at your level, you need to feel all of them, and you need to show your examiners that you know where to find all of them. All right.
Thank you.
All right, Chanel, do you still have a question?
Well, Doc, you answered my question a while ago in terms of I was asking if it matters to start proximal because I've been taught starting distal to proximal. So
Yeah, I
exam
really,
standard is proximal?
that's not exam standard. That's the way it should be done.
Okay.
A
Thank
standard, everywhere standard, around the globe standard. All right. So I'm not saying you weren't I'm not saying you weren't taught otherwise, but I wish you hadn't been taught otherwise, right? Blood flows from where? Blood flows from proximal to distal, right? So that's the way you have to examine the pulses. And I'm not familiar with it being done any other way, although I'm sure somebody may have told you that. All right.
Thank you, Doc.
You're welcome. Dorsalis pedis is a little bit medial to the tendon. What I meant by that is in the chat, it is towards the that could have been a confusing statement. So I will retract that. But what you're basically doing, because it's really not, the pulse is not really medial to the tendon. But if you feel for that tendon that's going to the first digit, then, and you put your fingers at the midfoot, towards the mid portion of the foot, that's where you will feel the pulse. So yes, I was referring to the midline. That's correct, Pierre Charles. Okay. All right. Okay, everybody. Good luck. All right. Don't sweat the minutia. This exam is not about minutia. This exam is about making sure that you don't spend your time dealing with that. All right. This exam is about making sure that you are safe. That you're not going to get a patient coming in with critical limb ischemia and you don't know what to do. Or you're not going to get a patient coming with a venous ulcer and you don't know what kind of venous ulcer.
Excuse me, Doc.
Yes, Mr. Rock. Are you asking a question?
Yes, please. One last one.
Sure, go ahead.
If you do the ankle breaking index and it is greater than 1.5, And
And
arthrosclerosis,
something is wrong.
arthrosclerosis is not an option.
No, but that there's no other option, Javon. There's no other option. It has to be, your ankle brachial index can be greater than 1.5 unless you have highly calcified vessels, which are not allowing you to compress them when you blow up the blood pressure cuff, right? So you can have non-compressible blood vessels where they're so calcified that you can't occlude them with the blood pressure cuff, which will give you a really high ankle brachial index, right? But that is the only reason that that can occur, okay? All right, okay, everybody. Take care, good luck on your exam.
Thank you so much.
Thank you.
You're welcome.
Thank you.
Thank
Dr.
you.
Brown.